go. So we'd like to welcome us here today, Dr. Renee Hartz. Dr. Hartz is a retired cardiac surgeon. She is the past medical director of the Chicago Center for Myofascial Pain Relief, and she was a cardiothoracic surgeon. She spent over 40 years working in medicine. Now she's semi-retired. You look like $1 million retired. She began incorporating myofascial trigger point therapy concepts to her medical practice over 10 years ago. She's a great speaker, and she's been providing us with research data and science. And this is Doctor's 4th time speaking for the NAMDPT, at least.
And I've been to, I did a poster presentation at Northwestern.
Yeah.
Before I worked with you.
Yeah.
And we went to Milwaukee. We had a poster presentation there. So in addition to the meeting presentation, we've had other
presentations as well. So Dr. Hartz's lecture information will be based on her 4,000, probably at least, trigger point injections that she's performed together with wonderful myofascial trigger point therapists, including myself in terms of the injections, and Sue Dimbert, who presented for us yesterday, Mike Pilney, Craig Qualia. Dr. Hartz is the primary author of over 100 PubMed peer-reviewed cited papers. So we're so happy to have Dr. Hartz presenting today on her approaches to trigger point therapy, including myofascial rejuvenation, a method that's trademarked by her and used in 40% of those 4,000 patient encounters at Chicago Center for Myofascial Pain Relief, where she worked with Mary Biancalana. So without further ado, Dr. Hartz, welcome, and great to have you here.
Thank you, Mary. First of all, I want to thank Mary, certainly. This extended career of mine, I refuse to retire. To me, that's the first step into the grave. But working with Mary and all the other therapists that I have in Chicago and nationally has just provided a fascinating challenge for me. And I really believe that some of the work I want to show you today that I've learned and hope to continue to teach are more important than some of the articles that I wrote in cardiac surgery. So I appreciate it. And I also want to, in my special thanks, mention Dr. Antonio Stecco, and really all 3 Steccos for the provocative, evolving research, including basic science, everything you can think of. All these people is almost as though Padua, Italy, where we would have the International Myopain meeting, is sort of the Sistine Chapel of fascia. So I will refer to them repeatedly. One final thing before I get started on this talk. Last night I reviewed Dr. Warren Hammer, a chiropractor, who after 60 years of doing chiropractic medicine, that term changes all the time, was actually involved in Dr. Luigi Stecco's courses. He sat in on them and he became friends. He eventually translated Dr. Carlos Stecco's fascia book into English from Italian. And his podcast is also on YouTube. Warren Hammer Lecture is fascinating, and it shows that his mind, he was a genius. And a lot of the stuff I'm going to say today, he said years ago. So let's see.
And just to let you know, I confirmed with everyone and they can hear you very well.
Great.
I
talk fast. That's why I'm thankful to Julie Zuliger for giving me a half hour, because Mary is trying to get me to slow down here. No, Mary.
All right.
Oh, okay.
No, go ahead. No, hit it
Okay.
once. There you go.
Okay. As in all presentations that have anything to do with science and equipment, whatever, I have to disclose business conflicts, financial support, whatever. And I can tell you I haven't had no financial support in any of my research since 2003 when I left cardiac surgery. Certainly no business conflicts. I've pretty much funded all my own research since 2003, and I've been happy to do so. To me, to teach, lead, write is more important than the financial remuneration from doing business, which I call medicine still. Finally, and most importantly, I have to reveal my licensure status. My Illinois medical license was suspended a year and a half ago due to something that happened years ago, an overbilling issue while I was working with chiropractors rather than with myofascial therapists. So currently I do not have an active license. Nonetheless, as you'll see from my activities, I've continued to pursue all my academic questions.
Okay, wonderful.
Overall, the purpose of this presentation is to encourage you as a group to become a shared interest group of the American Academy of Pain Medicine. As you know, the International Myopain Society is in a transitional state, questionable whether it will succeed, starting with COVID and whatever. So that leaves the AAPM, American Academy of Pain Medicine, to be the most prestigious, most basic science oriented, most clinically oriented, largely heavily into neurologic research in pain organization that there is on the planet. They've been in existence for over 40 years, and their journal, Pain Medicine, is definitely the highest peer-reviewed journal on pain in the country, again, if not in the world. So it takes 25 members. Mary and I have been working on trying to determine who would like to and what you may be hearing from us. You may want to contact us about becoming part of the shared interest group. The AAPM meeting is usually in January, so we're on a short schedule here, but we're going to work on it. This was the state of the art when I first presented at an AMPT TPT meeting. And Paul Ingraham, a physical therapist, is widely quoted in the physical therapy research. And these points of view that he has actually were in existence before the 2019 pain medicine. By the way, I'm putting the references on the slide so that you don't have very far to go to find any of them if you want to use them. Anyway, this was what it was. Trigger point therapy is experimental. The science is shabby. Using a bazooka for a mouse, and worse, good trigger point therapy is hard to define and define. So that's how I entered into the field. And when I first presented to you as a group, I suggested that either you interact more with doctors or doctors cooperate, form groups with more of you. And that's, I feel even more strongly about that today. This has got to come to a huge group. That you're doing the best therapy there is in medicine, and you need to teach everybody else, all the other pain practitioners. None of this was even mentioned at the recent AAPM meeting. Matter of fact, I spoke at this most recent AAPM meeting in January. I had a 10-minute invited flash talk, and I talked about sort of what I'm going to finish this presentation with, and that was comparing myofascial rejuvenation, which is my trademark, and Mary and I have been using it. I want the organization to use it, comparing myofascial rejuvenation to regenerative medicine, which is gaining incredible, it's just proceeding like crazy, and it's much more complicated, and I'll get into that later. There are more complications with regenerative medicine, and I have strong feelings about which is better. I'll get to those. So at that AAPM meeting, there was not really a myofascial section. There was very little about myofascial at all in the whole program. And after the meeting, this woman, Dr. Meredith Barad from Stanford, quoted Dr. Langevin, who's got a huge, huge complementary medicine grant. They both stated that we truly have no understanding of what a trigger point is or why it exists. I take issue with that. We'll get into that. I'm sure you all feel the same. I like this slide not because it shows Einstein, who's obviously a genius, 190 IQ, has no special talent, but he's only passionately curious. Now, I have a quote of his married. I don't have the other.
Here we go.
Okay.
My mistake.
Sorry, we're just on the wrong screen. We'll put a different screen.
I got it right here. Okay, Doc.
Okay. I love this. He also said, if you can't explain it simply, you don't understand it well enough. So that while we're watching this research into densification, spindle cells, whatever, every kind of research there is, basically, we, especially as mechanical clinicians, have to be able to explain it to ourselves, to our colleagues, and to our patients. Now, you may ask, what does this woman surgeon have to do with myofascial? What are my credentials? Why should I be talking to you about this? Why should I even have an opinion? Well, this is where it is. Obviously, as Mary said, I have a surgical career. I was a tenured cardiothoracic surgeon, professor, blah, blah, blah. I had a training program, which is really difficult in surgery, and especially cardiothoracic. Cardiothoracic surgery is the smallest surgical specialty. So that I was in a very privileged group way back then. After my third tenure battle, I won one, lost one, and tied on one. But anyway, I was a tenured professor. I was program director. I then went on to do trigger point injection training in 2010, simply because I had found Amber Davies' book, the Davies book, at my son's house in Wyoming, which all the athletes and skiers injured themselves frequently, and that trigger point therapy workbook was at their home. Everybody out there has it. So I did that injection training, and then I began to work in a chiropractic practice as a medical director. And I worked in a couple of different chiropractices. I had at that time probably over 5,000, definitely over 5,000 patient encounters using something old-fashioned called Serapin, which I'll get into later. And there was no soft tissue work or therapy after the trigger point injections. So after learning how to do these injections, I did them in an isolated sense without any myofascial therapies following it. Then in 2014, I began practicing in a bunch of clinics, ending up with Mary, where I still am joined at the hip. And I wrote my first monograph on the first 500 patient encounters using the old Serapin technique. Finally, and this is the most recent, with Mary, I have data, but it's simply records that I kept at my desk. Those charts are paper. There was no VAS, visual analog scale comparison between pre and post treatments, but I can say that in my at least 4,000 encounters, the 2 days I worked there from 2016 to 22, I did a little over 4,000. I saw 4,000 patients, incredibly deep physical exam and all that, like I'm used to from medicine. And 40% of those patients had trigger point injections now with bupivacaine, which is a very long-acting local anesthetic, allowing their subsequent therapy to be even deeper, and combined with what is now known as pitcher plant extract, which is the generic for what used to be Serapin. Okay, so just this year, as I said, I attended the AAPM meeting in Fort Lauderdale. I gave that talk on myofascial rejuvenation. Didn't have a very big attendance, but the responses were very enthusiastic. I also was an exhibitor for the Rebuilder medical device for peripheral neuropathy, which I have presented my data on peripheral neuropathy previously, and I'll go back to it just for a minute today. I also attended 2 courses in Las Vegas, one ultrasound guided pain procedures, and one with joint extremity injection courses. Now, this is young people, nurses, nurse practitioners, PAs, all kinds of clinicians learning to do joint injections with ultrasound guidance alone in a room. The ultrasound procedure has become so simple that you can do it in the patient's room with an iPad and a simple little probe. However, a word of warning here. Ultrasound guidance has been advocated for trigger point injections for years. And some of the courses online state, do the ultrasound or you won't get any reimbursement. That's pretty much and now unfortunately, it's going to be used more and more and more because reimbursement is otherwise so poor by the third-party payers, by Medicare. So anyway, we do not use ultrasound guidance. We believe in physical examination being the gold standard. Even more importantly, and this is currently the most contested area of medicine, of pain medicine, as judged by this meeting I attended and all my reading. The joint injections, especially SI joint, is an extreme flux. The payer status has changed dramatically. These clinicians aren't able to do the SI joint and nerve injections. Nothing's being allowed. I worry about that because it's technically very difficult, at least in my opinion. But that's the state of the art. So we have to wait and see what's going to happen. All the pain clinicians are getting very upset that they can't get reimbursed for anything unless they use fluoroscopy, X-ray. That adds another huge cost. And finally, both Mary and I attended a conferencing call at the NIH, a grant held by Helene Langevin in the complementary medicine section, a huge grant for studying biomarkers in myofascial pain. That's a subset of the grant. And we were on that conference call and hope to be actively involved with the grant in the future. Before I really get into the myofascial issue, I want to question some assumptions that I've had on and off through all of my medical career. One, skin is the largest organ. Skin is the largest organ. What is skin? I'm going to get into that. Skin is not the largest organ. Another quote frequently is muscle is the largest organ. And if you think about that, the little thin elderly woman has the same muscle mass as a bodybuilder. So the amount of muscle is, it's very individual. And also muscle is 75% water. Now, is skin innervated? We'll get into that more and more because I'm going to show you some of that research. And really most importantly for today, is muscle itself innervated? Muscle, we have to figure out what skin is. We have to figure out what muscle really is. Okay, so the human body in infancy, 80% water, goes down to about 50% in octogenarians, older people. In infants is very, very high. Connective tissue is the largest organ system. Connective tissue is bone and soft. And you all are very familiar with tendon, ligament, cartilage, and then the fascia, and we'll get into the layers of the fascia especially in the deep fascial system in this talk. And I hope you agree or at least can argue with me on any of these points. Okay. This is another issue. I don't know why people ever use the term myoneural junction, because actually it's the nerve that, do I have a pointer? The nerve that connects with the endomysium, the paramysium, and the epimysium, which I'll get into a little bit. But
here you go.
Okay.
Move your hand right on that circle.
So this is actually the nerve, and this nerve literally innervates the epimysium, which is the outer layer, the paramysium, and the individual fibrils are covered by endomysium. The innervation increases more and more as the layers get deeper and deeper and the fibers get smaller and smaller, so that every single myofibril, and by the way, a myofibril is a cell. A myofibril is a muscle cell. So muscle cells are in the nuclei of it's the only tissue where the nuclei are on the edges of the cell. It's a gel. Actin and myosin is gel. In any event, my opinion is, and I've seen this over and over, the nerve does not cross into the muscle, the actin and myosin. The nerve interacts with the endomysium, the thinnest layer of fascia that covers each individual muscle fiber. Okay, so I like this slide just because it's so pretty, but we really only have 4 tissues. And epithelium is not epidermis. Epithelium is usually a single layer of cells that is simply a waterproofing layer. There would be no way to prove if the epithelium has sensation, but none of the subsequent slides I'll show you show that epithelium is innervated. Muscle, now here it is. Remember I told each myofibril, the direction of this contraction would be this way, not this way. It's very important. It's actin and myosin and these fibrils, and again, I'm not sure the nerve really gets to the muscle itself, muscle, actin, myosin. The nervous tissue and the connective tissue are much more sophisticated. And the highly innervated nervous tissue obviously extends into the connective tissue from the outer layer to the inner layer to the endomysium, highly innervated as you get deeper and deeper into that muscle bundle. Okay, just a little bit about skin now. I said, what is skin? Skin includes the dermis, it includes the epidermis. The dermis is 50% hyaluronic acid. The skin is, but we need to be more clear. We'll get into this later, but the terminology is what's goofing everything up. However, what I wanted to say, and especially Kathy Cohen's lecture today with all the gliding and the skin therapy before proceeding with the muscle therapy, because of the hyaluronic acid, these layers are able to glide over each other, especially the subcutaneous or subcutaneous tissue, we call it, over the deep fascia. Now, this is the layer that surgeons are very, very familiar with. Here, the dermis. That's what we sew. That is what we really need to call it. We can't sew epidermis. It's one cell layer thick. So we sew dermis on the back. It's very, very thick. And so it becomes a great place to teach residents how to suture skin. Okay. But why is skin is obviously very important because of the issues discussed by Kathy Cohen and everything else you've read, but also, and this is a finding that I feel pretty strongly about, there are increasingly more papers about the presence of small fiber neuropathy in all the autoimmune conditions, rheumatoid arthritis, lupus, fibromyalgia, you name it, anything that's autoimmune in nature is going to have a certain incidence of small fiber neuropathy. And in our clinic, every patient that we've done a skin biopsy on, in whom we suggested or knew had a diagnosis of fibromyalgia, had a skin biopsy, every single one of them has been positive. So that none of the literature shows 100%, and we probably only did 30 because I was unaware of small fiber neuropathy originally. But presence of small fiber neuropathy is very important. And the other issues, the neurologic input, whatever, they're discussed at these meetings, but that's not really what we do. What I found really important in your practices, if a patient has neuropathy or any numbness, tingling the feet, especially sometimes hands, look for increased knee reflexes. If the knee reflexes are absent, it's going to be a large fiber neuropathy, which is treated differently than small fiber neuropathy. And this should say hippus. Hippus is pupillary athetosis. If the pupils go up and down on their own, that means the adrenals are depleted. Those patients all will end up with a positive skin biopsy. I actually tried to propose this term as a trademark, was what granted the trademark, but I think eventually that small fiber neuropathy will be termed fibroneuralgia or some variant of that term. Okay, this is skin punch biopsy. And again, just to show you, the epithelium is one thin layer up there, and the nerve fibers in the skin are subepidermal. Okay, and here's a dermis that separates the skin from the rest of the tissues. That's just to say that, to show you that we can diagnose that. And if you need to refer the patient for the biopsy, that's fine. Any doctor can do it in their office. Okay, therapy for the superficial fascia and nerves, and some of these therapies overlap into deep fascia, or skin rolling, as you saw this earlier today, cupping, spray and stretch. We don't do anymore, although Travell championed it because of the toxic effects of the sprays, and we're not really allowed to use those anymore. Then, really importantly, regular TENS, frequency-specific microcurrent, which Shannon Goosen was going to talk to you about, and we'll be talking to you more in the future about frequency-specific current. And then there's a new therapy for superficial fascia, which is, again, it's going to be pushed into the deep fascia, of pulsed electric therapy. And it's a needle insertion technique that is used frequently with dry needling and with other of the regenerative medicine techniques. Turns out that in the last year, some of the articles have shown a very, very high incidence of extreme pain with this procedure. I'm not sure that that's going to continue for too much longer. And then heat and light therapies, which are a big part of the NIH grant that's going on. And we know from all the literature the research that's being done, that heat, and especially the heat component of light, loosen the densification, loosen the viscosity, make gliding easier. Matter of fact, at a temperature of 104, that's the maximum amount that the fascia can stretch with heat. So this is just, I think I've presented this to you before, but to show that the one's frequency-specific microcurrent is multimodal, and you pick what you're going to treat, and that's Mary's expertise and Shannon Goosen's. My expertise happens to be with a specific frequency, a very low frequency, 7.83 Hertz, which is the frequency we live at, which definitely seems to heal the nerves in large fiber neuropathy. So just so that you know that we have some data. Okay, I'm finally here to the objectives of this presentation, because previously it was just, what is our purpose? So I want to define both the myofascial unit and the trigger points. elevate fascia to an organ and fascia and the myofascial unit, Dr. Stecco uses this term now, Dr. Antonio Stecco, to an organ system. A little bit more about gliding. Really importantly, to explain referral pain. Is it really referral pain in a myofascial unit, in all myofascial units? And then to describe some of the current treatments and what I consider to be the best. Okay. What is a myofascial unit? First of all, the origin of the unit and the insertion of the unit are both called entheses. Entheses. Just to point out, yesterday, Sue Dimber talked to you about Ehlers-Danlos syndrome illnesses, and those are enthesopathies. We have to get rid of a lot of other terms, myalgia, myositis, tendinitis, spelled two different ways. We have to get together on the nomenclature so that we can understand this. In any event, the origin is always on a fixed bony structure. The insertion is always on a movable bone and often crosses a joint. The contraction of the myofascial unit begins at the neuromuscular junctions, or very near the neuromuscular junctions, which happens to be the thickest and bulkiest part of the myofascial bundle. Furthermore, the contraction is unidirectional, and it contracts towards the origin. In other words, the origin of the myofascial unit pulls the insertion toward it. I'll show you that in a couple of slides because it's really important. And then the fascial layers, there's the muscle bundle is covered by epimysium or sometimes an epineurosis, an even thicker form of epimysium. Then the perimysium around a muscle fascicle, and then endomysium around the muscle fibril. Those names of those layers aren't as important as the fact that they all merge into the periosteum of the bone to which they attach. And of course, the extracellular matrix contains this hyaluronic acid that a lot of the research is being done on today, and the importance of the hyaluronic acid. By the way, your skin is 50% hyaluronic acid, or 50% of the hyaluronic acid in the body is in your skin. So you'll see all these commercial products. Okay, so here's the typical myofascial unit. Let's just go back here. This is 1543, Padua, Italy. Unbeknownst, Vesalius, I've shown this before, showed the first clear picture of a myofascial unit. Here's the muscle has been dissected off the spinal column here, and it's shown with a very small insertion into the periosteum of the humerus. The endomysium of the fascia and the periosteum of the bone are sisters, they meet. So that's just a picture of the first publication by Luigi Stecco in 1987, and he refers to this fabric and also points out that the acupuncture system was contained in this. Now I'm going to, at the end of my presentation, I want to give you a couple of the findings of Dr. Warren Hammer's lecture I mentioned previously, but I want to tell you some of his conclusions were because of his very close relationship to Luigi Stecco. They were friends, they taught together, and on. Okay. From the muscle to the myofascial unit, current evidence and future perspectives. Now, I show this for a lot of reasons, but this wasn't this year. This is this year, and the term enthesis is not used in this paper, nor is it mentioned in several of the other references I have. The term enthesis came from the rheumatologists just after 2000, 2005, something like that. It's been used in rheumatology, but we aren't using it. So it's really, really important that we get back to that. Okay, so like I said, the Sistine Chapel, it's almost religious. Warren Hammer calls it philosophical, but it's sort of like the Father, Son, Holy Ghostus, in my opinion. But it's fun to think about it, but it really, truly is. Padua, Italy really is the epicenter in the world of fascial research. Okay. As I said, the enthesis at the origin is almost all collagen. It's thick, tendinous insertion. It doesn't have a lot of smaller and smaller layers that the other end, the insertion, has. That's why I do think that maybe the terminology of the origin should be changed. And the word origin is hard to say in medical speaking. So maybe that will eventually change. then the deep fascia, which, like I said, epimysial aponeurotic. But here is the important thing. Between each of these layers, extracellular matrix, fluid, rehydrate. Dr. Passamonte mentioned all his R's for his methods, his MELT method. I agree with him completely. We need hydration. Keep this extracellular matrix healthy. I think we can skip that. We've pretty much covered that already. Okay, so Dr. Luigi Stecco, again, earlier, 2003. Oh, I think he added this photograph with the other reference I told you. And the only thing I've done here is color in the interstitial connective tissue, because it really is interstitial fluid or extracellular matrix. But because of all these other connections, the myofascial unit is an organ, a sensory organ, a proprioceptive organ, a nociceptive organ. It even has filters. People who sleep too long at night, who don't walk much during the day, who are always in a lazy boy chair, are going to have edema because of increased swelling in their myofascial units, which can only be resolved by briskly getting up and walking. There'll be more of this research in the next couple of years, because there definitely is a correlation between inactivity, cold, and worse myofascial function. Okay, I wanted to show you this because this is the classic picture of the innervation of a myofascial unit. This here is paramecium and endomecium only. You can't really see the yellow on here, but every single one of these fibrils, every fascicle is innervated, and it should be yellow. We, and me, are not as familiar with, not as educated in the neurologic conception. They are extraordinarily important. And Shannon will be talking to you about that, but we are more, at least from my perspective as a surgeon, more the mechanical part. And I'll show you one of the extracellular matrix later. Okay, what is a trigger point? It's not a mystery. It's a palpable knot in a taut band of skeletal muscle, period. Several of the most recent papers on trigger points still say that they are tender points. And I can say, from having examined and injected and worked with the therapist on, it's frequently not tender. It's frequently just sitting there twitching. Now, concerning the twitch, we have found in our practice that the twitch is more common the younger the patient is, at least that seems to be. But it does not, the trigger point does not need to be tender or have a twitch. The most important reference in this area is Dr. Gerwin's 2018 article in Pain Medicine on a consensus point of what a trigger point is. And he would agree with the question of when these occur and when they don't, that they can exist in all, a trigger point can occur in a latent state, an inactive state, all kinds of states. Again, that they occur at or near the neuromuscular junctions, which is key to where we're going to inject them. Because even if you don't find a trigger point in a severely diseased or dysfunctional or painful myofascial unit, it still pays off to inject near the neuromuscular junctions, even if the trigger point isn't well formed yet. They always indicate myofascial dysfunction. Another important concept, again, this Dr. Hammer, who wrote this thing in 2018, suggested the same thing that I have thought about often. Trigger points are like compartment syndromes. I'll show you a little bit about my experience with compartment syndromes in cardiac and in general surgery. But a compartment syndrome has inflammatory mediators, especially these two interleukins, substance P, tumor necrosis factor, and are very acidotic. They're at acid pH. That's the same thing as a trigger point. So basically, these trigger points to me resemble very small compartment syndromes. So what can we do clinically about trigger points? And as I said, I do still firmly believe that physical diagnosis is the key method of diagnosis, and that the ultrasound techniques that are being talked about more and more are not necessary for soft tissue trigger points. Several things to point out on this slide. Okay, I haven't done this, so.
Okay.
I hope after this slide that it'll change its mind and let us advance. Any event, gliding fluids of myofascial units. I'm not sure if I'm going to show you this slide, but I have pictures of the cardiovascular system, of the pulmonary system or the GI system. They all have fluids. They all have fluids between their layers. They all glide to some extent. And the normal amounts of these fluids is very small, a couple ounces for the pericardium, a couple ounces for the pleural fluid, maybe 30, very little fluid normally. In pathologic conditions, they not only increase, but their viscosity changes, or densification in the myofascial unit. So just to remember that all these organ systems have 2 layers of fascia, called various things depending on their location, with a fluid layer between them. And they have an endothelium or an epithelium. They have a single layer of cells lining them. This is so that everything can function and work. All the interstitial fluids are produced by early premature cells. They're called mesenchymal cells. And Carla Steckel has recently named the cell that produces the myofascial fluid to fasciocyte. These are all fairly new things and very exciting. Now, let's just hope this advances.
Click it once and then pull away. There
Okay,
you go.
so they all contain collagen and elastin to various degrees, hyaluronic acid to various degrees, especially the myofascial unit. And if the fluid is healthy, the pH is normal, the gliding is good. If there's enough fluid and it's the right composition, the myofascial unit will function perfectly. And if not, they become what Dr. Antonio Steckel called densified, and there are proteins called aggregens that cause this densification, and they don't move well. They're stuck, especially near the trigger point. Okay, so this is a venous diagram for the myofascial unit, but I've changed it to the extracellular matrix. And if you notice, here is the epimysium, then paramysium, and then even down to the endomysium. Every single one of these should be circled in blue because there's fluid surrounding every single fiber. Okay, so I've said this already when we were waiting for the slides. The myofascial unit is very sophisticated, and is capable of all these functions: proprioception, nociception, on, even filtration, and as mentioned previously by other authors, contains the entire acupuncture system. So are we really talking about referral pain? Well, I said previously the contraction starts at or near the myoneural junctions. So the origin is pulling on the unit. The contraction starts at the myoneural junctions, then the insertion is pulled towards the fixed part of the skeleton. The referral pain, is it an enthesis of the myofascial unit? This is where the endomysium meets the periosteum, blah, 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 blah. Is that truly a referral pain? And is it inflamed? I don't personally believe they are always inflamed, because we don't see the cardinal features of inflammation. We don't see heat, swelling, whatever. So is this just a mechanical pulling on the periosteum that's causing the referral pain? I will say in one location, I think it's very clear that there's referral pain from a myofascial unit, and that's the rectus abdominis, which sits on top of the transversus abdominis, on top of the peritoneum. So the rectus, despite the fact the fibers go up and down, the rectus refers significantly to the back. Okay, so here's the picture. Now, the apps are important. I've been using this app, Essential Anatomy 5, for 10 years. And it's on my iPad. I bring it into the patient's room. And this is because Vesalius is the one who discovered this. The contraction pattern is very strong. And it's the insertion over here on the humerus is about $half size, but the muscle bundle is myofascial unit is being pulled towards the spine. This is fairly vascular. They're minimally vascular tissue here. The referral quotes is toward the insertion on the humerus. And now the second app, this is also a wonderful app. And this one I just got a few months ago. This one has videos incorporative of a therapist actually doing therapy. But notice the X. I had the big referral point drawn on the previous slide. That's where we end up getting the twitch. That's where we end up doing injections. And guess what? Then the therapist who treats the patient afterwards can disperse all this lidocaine and anti-inflammatory pitcher plant extract throughout the entire muscle bundle. Once you see a few of these, now a little more complicated, here comes the trapezius. Trapezius has 3 zones: ascending fibers. Again, look where they, I'm getting a little frustrated, but okay. ascending zone. The origin is on the scapula here. Okay. And but we'll just say, because it has 3 zones, there are at least 6 different trigger points. Just let that be. Again, I recommend both apps. Okay. Finally, the 7th objective, describe the treatments. Dry needling, everyone here is very familiar with, and Dr. Dommerhold publishes 6 months on the updated this dry needling literature. I trained in dry needling before I did some of my other training. For the most part, dry needling consists of coning or stippling the trigger point. Coning or stippling, multiple sticks for angling the needle. I never did practice that coning or stippling. I have always performed 1 injection to the trigger point, whether in chiro or with myofascial, any practice. But the coning or stippling to me represents a mini fasciotomy. It's a way of reperfusing the myofascial unit, curing the trigger point, but mostly it's, like I said, a fasciotomy. Any tissue that is under too much pressure or decreased arterial inflow is going to become a compartment syndrome, and this is one of them. So currently, wet needling is what regenerative medicine consists of. The wet needling uses lidocaine, which is short acting. I don't use lidocaine anymore because it's too short acting and questionable onset, but also anti-inflammatory agents, almost always steroids, sometimes platelet plasma, sometimes prolotherapy, sometimes even Botox recently, all kinds of different, and to me, it's a combination of inflammatory and anti-inflammatory medicine. And of course, the other treatment that's extremely important is compression, both of the trigger point and the myofascial unit. Both can be treated with this. I think I've pretty much covered this already, especially since we're behind. I'm going to skip it. Okay, what is my experience with reperfusing tissue? All the time in cardiac surgery, we saved lives and saved cardiac muscle by altering the conditions of the reperfusion after we made the heart ischemic. You have to make the heart ischemic to be able to operate on it. It can't be moving while you're sewing a vein to a little tiny 2-millimeter artery. You have to stop the heart. And if it's a sick heart to start out and you don't properly reperfuse it at the end of the ischemic period, the mortality rate is pretty high, and the leak of CPK enzyme is extraordinary. So I had a lot of experience with this, and I'm involved in some of the major papers on cardioplegic solutions and cardiac surgery. I also have experience with reperfusing a limb and successfully salvaging the limb. But I think that with trigger points, it's sort of the same situation, but not to a major degree. Now, one difference between the ischemic tissue in a myofascial unit and the others that I've mentioned, the heart and the leg, that the myofascial unit tends not to undergo fibrosis for some reason. For some reason, it's just as vascular near the trigger point. It just doesn't undergo fibrosis, which is good because you can save that entire myofascial unit. Okay, now here's these are my observations and opinions. In myofascial rejuvenation, our technique, the needle is very short, 3/4 of an inch, sometimes even a 1/2 inch. It's hollow so that you can inject. Regenerative medicine, it's very long needle, and at least 1.25 inches. There have been some tendon injuries, there have been some significant hematomas, etc. I'll get into that. I use bupivacaine, which has a very predictable, long-lasting effect, and regenerative medicine pretty much uses lidocaine. I think they will change soon, especially if they're referring the patient for manual therapy afterwards. The anti-inflammatory, and I'm very, very, very sure of this, the pitcher plant extract lasts 3 to 5 days minimum. As such, it's essentially an injectable NSAID. It has not been called that in the literature yet, but there's intravenous Tylenol now. This has a long half-life. I see it as a perfect alternative for emergency room use, acute injuries, for perioperative pain. So on the other hand, in regenerative medicine, the steroids, they may take days to weeks to be effective. Prolotherapy, PRP, stem cells. I'm not sure anybody should get stem cells, and certainly the only true FDA-approved indication is for leukemia, other hematologous cancers, where the stem cells are taken from the donor themselves. the patient is radiated, they remove the patient's own. I don't think that stem cells from another donor are appropriate for, especially for myofascial treatment. Myofascial rejuvenation, I've not had a single significant complication of this, close to 10,000 between the chiro and the myofascial clinics. In the regenerative medicine, I read an article recently that at least 50% have significant pain, if nothing else. I'll get into the reason why I think ours is a little bit better than that. And the worst thing yet is if you add the pulse electrical activity to the regenerative medicine, that's injecting the needle and giving pulsed electricity, the pain is even worse. So anyway, trigger point injections without ultrasound are definitely the least expensive. The benefits include adjusting the pH, making it more alkaline than acidotic, like the trigger point normally is, and the volume expansion, which can be spread out by the therapist. I do not think they should ever be injected without having some kind of manual therapy afterwards. The benefits are clearly due to the multimodal nature of the therapy. The reimbursement is poor, and that all needs to be revisited because this field is in such flux right now. I've had several different clinic directors, one in California, one on the East Coast, one in the Midwest, who called me and asked me to explain why my patients seem not to have much pain. And I really think that it's a combination. Our clinic's like a little chemistry lab, and through this whole thing, I eventually got the injectate to almost normal pH, and all the 4,000 patients I mentioned in Mary's clinic were treated with this optimized solution with a normal pH. Now, we can't skip self-care instruction. That's what Julie calls, what's for self-care? Active recovery. Okay, so the therapist and the patient together should learn the anatomy of the myofascial unit that's in trouble. It's really important. And here's another thing that Dr. Zuluka said somewhere in her presentation: to compress before you stretch. I feel very strongly about that. As a matter of fact, the stretching literature still has not proven whether sport performance is improved and whether muscle soreness is decreased using stretching, which is interesting in view of all the stretch labs that are happening around the country. I firmly believe that Julie's methods of minimal, to compress in the direction or stretch in the direction after you've compressed, then we might see better benefits with stretching. That's still remains to be clarified. Maintenance therapy. This is a patient of Craig Quaglia's who actually we did see in Mary's clinic for a while, who in 1974 was high jumping, both world leader, world number one, what's it called? Anyway, here he is. He's been seen in our myofascial clinics for 6 or 7 years. And despite a serious illness and whatever, this man in 2021 in his age group won this contest again. I think he does both high and low jumping. He has been getting weekly maintenance myofascial therapy and doing his own self-care through this entire period. Okay, this is just the direction matter, and what is referral pain? This you've probably all seen this picture. Okay, so in this incident, just take this picture now. Here's the fibril in this direction. And here is the ultrasound all shows this image of this pulling into the fascia. I don't know, I missed that slide somehow. I guess But what if you are not directing your massage or deep therapy of whatever type it is? What if you're doing it like this? That would be wrong. The point is to lengthen this entire myofascial unit, remembering that it gets thinner, and more fluid as you get over to the insertion. So here it's very tough and stiff. You're not going to change that. Here is you want to relax the insertion of the myofascial unit. I always think of the Achilles tendon too. If you keep lengthening your Achilles tendon when you're treating your calf, you're very unlikely to end up with Achilles tendon rupture. Famous athlete had that happen recently with almost no significant trauma to the ankle. It was unheard of. Anyway, I love this. The ultrasound will also show this. I have another picture. This was just on one of the social media sites last week. This machine rubs in a circle. Is that really what we want to do? I do believe that the direction of the massage matters. Dr. Zuliger, Dr. Biancalana do.
Doctor.
And of course, Spring Fawcett, the Tiger Tail Instruments, and Renee Gladio, the back number, and the soft balls. I like them because depending on the size and the accessibility of that muscle group, for example, I love this instrument here in place of the tennis balls because I don't have a wall space in my house to use a tennis ball with. But this is great for carpal tunnel, for the neck, for areas that, you know, that its tiger tail just can't reach with. And as far as foam rollers, when I was in the chiropractic practices, almost nobody went home without one of the big, large, stiff foam rollers. They tended never to use them. The tiger tail, you can adjust it. You don't have to run it straight up and down your back. You can go into the transverse abdominis. It's very flexible for all sorts of uses. So basically, musculoskeletal and the red man skeleton that most of us have in our offices just does not describe the myofascial unit. David Lasondek's book here, which is 2021, I believe, is an excellent summary. All the stretching I talked about, all the things that I've mentioned briefly are covered in that book, and I strongly recommend that. Now, in your presentation, all the references will be covered either with these pictures or the reference will be stated on the slide. This is the most important thing. I mentioned enthesopathies, enthesitis. What I have not included here, because I read this recently, is that the rheumatologists were really the ones that came up with the term enthesis. So we all need to get together. We all need to be on the same page. We need to get this therapy out because it's the best, it's the least expensive, it's the most proactive, it allows just better health, period. Finally, I did not say much about the neural connections, but the myofascial units are highly innervated, not at cartilage, which is aneural, not very much at the origin of the muscle. That's pretty much avascular and aneural also, but the epiperi and endomysial fascia is extremely highly innervated. Extremely, it's like the soul. So I don't really believe that trigger points are a mystery, especially concerning their location and their composition. We know all of that. There's tremendous amounts of research on that, starting with Schleep, and Mary will name all those people. I don't believe that musculoskeletal ultrasound is really necessary for trigger point treatment or myofascial treatment. However, it would be a fantastic new research tool because it's now portable. We can take it into the patient's office. So then we can solve the issue that really is in question, and that is the temporal relationship of the trigger point and the myofascial unit. My strong opinion is that a trigger point should be called a triggered point. And I would suggest that the dysfunction occurs because of all the perpetuating factors you all are aware of, posture, overuse, blah, 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 blah. And that eventually the trigger point forms. When it is, I'm not sure, but certainly is the most ischemic part of that myofascial unit. And we've discussed the ways to relieve that as well as the myofascial unit pain itself. Finally, Serapin. Serapin was only around for it's been around since 1940 for its veterinary use, especially in horses for horse laminitis. And even today, what's left of Serapin is being used in these multi-million-dollar racehorses for myofascial therapy. Actually, in Canada, they can inject a horse. I'm missing what horse is, but equine can be injected 24 hours before. In my experience, the Serapin, which is now truly has to be called pitcher plant extract. Serapin is no longer, it was always FDA registered, and the insurance companies accused all of us using it because Serapin was, quote, not FDA approved. Botanicals do not get FDA approved. So this is now marketed, but the company listed here, USS Formulations, as pitcher plant extract. Its onset is 18 to 24 hours. It lasts days. It's phenomenal. It's inexpensive. And
I've got a question.
go ahead.
Could you go back? So I think it might be worth it, Doc. May I ask you, could you reiterate a little bit more about number 3? How would you describe that temporal, and forgive me personally for not understanding, what do you mean by temporal relationship of the trigger point and the myofascial unit pain?
Because Gerwin's paper 2018 really discusses all of this. I strongly recommend that paper. But sometimes there is no trigger point. You don't have one, and you have this severe myofascial pain and dysfunction. So in that particular person, is the junction of the myoneural junctions, are they more vascular? Is the trauma worse? Nobody really has proven which comes first. I think I have that on the next slide. Chicken or egg.
Yeah.
But that can be easily determined. And basically, if they have a trigger point, treat it, but never treat myofascial pain and dysfunction. I mean, never treat myofascial pain and dysfunction without manual therapy and self-care, because the trigger point is just going to come back.
Because you're saying just doing the injection, which happens many times all over the country, people are going to a practitioner, getting trigger point injections and going home and sitting on their butt and doing the same old stuff they've been doing. They're not giving stretches. They're not giving home care. They're not remediating. They're not making changes. That's what you're saying.
That's the way it's taught.
I
That's the way
see.
I did my first 7,000 inpatient encounters. That's the way it was taught at this huge course in Atlanta. PAs, NPs from all over the country, and me. And fortunately, because of my scientific curiosity, I had to know more. I had to know what is going on here.
Yeah.
And as you know, we've adjusted this.
Right. So then maybe we as a group need to get a great physician educator, because now Dr. Hartz is at this moment retired from any of these procedures. We could request you as a great medical educator. Can you infiltrate these meetings? We
should start with the AAPM in January. Whether we are just mentioned as a group, we form a group and we can't yet present, certainly the year after. You have to get this across. There are hundreds of people at this meeting, and nobody knows anything about myofascial. I was astounded because the MDs tended to come to my little flash session on my methods, but they're clueless really as to what you're doing.
Yeah, it really is pretty amazing. So you're on the inside of these medical meetings and you're realizing they don't have a clue. And I know Dr. Gerwin, and I know even Dr. Jim Frickton. We've had both of those great speakers together at our meetings in years past. They've been doing their best to try to get a special interest group on myofascial pain at some of these bigger medical meetings. And it's difficult to get, people, other medical providers interested, because there's not big money in it.
I hope to be the messenger, so don't shoot me.
Okay.
I'm only the messenger.
Right.
I can definitely develop a relationship, especially there are a couple of people there who are just phenomenal that I'd like to contact about this. And all of you consider belonging to the special interest group that we hope to form of the American Academy of Pain Medicine. It's a huge meeting.
Mm-hmm.
So, okay. This, as I mentioned, this joint injection procedure, look at this. This is a single person, supposedly a single person in a patient's room, practicing sterile technique, all these various ultrasound probes. This particular system, this young person who taught this course, had an $85,000 ultrasound machine and all these very expensive probes. Whereas really, in my opinion, if you have to use ultrasound, make sure the joint space is there. Put the ultrasound on the joint. The joints are always right beneath the skin. And these clinicians are introducing the needle at a long distance away from the joint and traversing all these other tissues, and they're going to get hematomas. They're going to get tendon injuries. It's very difficult. And I don't know how they would maintain sterile technique. And an infected joint would be, to me, the worst outcome of doing treatment of a joint. So here it is. Who came first? And like I said, I like to call it a triggered point, because that's how I believe it happens. But we can prove that. We can decide that with an ultrasound study. Inexpensive. These are the courses that I attended in Las Vegas in January. One of them was the day of the Super Bowl, so I skipped out at the end. But those were great. And this was just a couple weeks ago. This podcast with the American Academy of Pain Medicine concerning these SI joint injections and all these local coverage determinations, LCDs. They became effective in March 18, 2023. That's how recent this is. And there's a huge outcry from all the pain societies about not letting them do their typical pain relieving SI joint injections. Are we getting better? Well, it's spreading, but are they getting better? I don't know. Okay, and I think we've already said this. Picture plan X-ray. Okay. I think I've already said this. Those 4,000 patients in CCMPAR with Mary, trigger point injections, and 40% of them without a single serious adverse event or allergic reaction. The records are available if somebody wants to, has the money or the grant to study the visual analog scores before and after the injections. But I don't have access to those records at this point, and I have never had any secretarial help, research grants, anything like that since 2003. And that would be impossible for me to do at this point, but it should be done. There it is. Use a bazooka to treat a mouse? No, use a bazooka to treat an elephant. And you shouldn't shoot elephants anyway, but I just thought of that now. It doesn't fit. Okay, and the references, I did not show you these two books, which of course, I've showed you Carla Steckel and David Lasondak's book in the presentation. But of course, the Trigger Point Therapy Workbook and Travell's magnificent work can't be ignored. Now, I will say this. If you use the apps, if you use the Essential Anatomy 5, that's an Elsevier app, it's cheap, and the Trigger Point apps, you do not have to have this book with you at all times. It's become so easy now to quickly scan to that picture on the app, take it in the room with you, show the patient. This is very important for those of you who want to be board certified in myofascial trigger point therapy and to do research, but for the clinician on a day-to-day basis, I think the apps are very, very useful. And I love them.
All right. So first of all, yes, there were some questions, Dr. Hartz. So let me escape this. So Christine Maya said yes, exclamation point. She's in for the special interest group. Yay. And then Leslie Marshall, thank you for your question. Leslie also said, how can we join? And there was a question mark and an exclamation point. Leslie, you're so great. So yeah, thanks for that. So I think I can also let everybody know that, let me get rid of that. Let me pin you. There we go. 1 second. Okay, so we could let everybody know that Dr. Hartz and I have both been working with the IMS, the International Myopain Society, and Sue Dimbert, and many of you from years past. I know Vicki McGowan and many of you have been involved with the IMS through the years. Unfortunately, they're just not able to survive for lots of reasons. But Dr. Gerwin, you know, because also Dr. Hartz, you were on the board. Dr. Gerwin has been pushing and pushing and pushing, trying to get the special interest group, and he has the parameters of what's actually needed. I know that you and I both know he said 25 people minimum. And so the NAMTPT is going to be spearheading information gathering now that the IMS was going to originally be doing it, but they're again not probably going to be defunct as they're non-for-profit. So we're it, people. We're one of the last ones standing. And so we'll be getting information to you through our NAMTPT newsletter. And we're also through Dr. Gerwin, when he was working with the AAPM, I let him know that there is no way many of us, well, there certainly is, but I wanted Dr. Gerwin to negotiate with the AAPM a lower membership rate for those of us that are licensed massage therapists versus licensed medical doctors or anesthesiologists, et cetera. And so I know Bob Gerwin was working on that, so I can send him an email on Monday, and then I will, I'm planning to become a member. I know Dr. Hartz is already currently a member, but what we need to do is get them ready to have us designate this SIG, and they have to make that available on the membership application. So we're not going to step forward on that yet, but we got to do something pretty quickly. We wouldn't probably be able to get a place at this year's meeting. I'm sure the speakers are long put in, but urgently now we have to get our 25 people, because if we want to have a representation at what will be their January 25 meeting, we need 25 people to join probably by February, because they're setting the speakers and open for speaker applications probably by February for the
Actually,
25
there was a
meeting.
deadline already, but they have open space.
No, I meant for the 25.
yes.
We'd love you to get
Yeah.
in there to an open space. And
Yeah.
if the NEMTPT could help to sponsor you to go, Dr. Hartz, we can talk as a board and have you at least get in there representing myofascial pain. So thank you for that.
Couple other things, by the way.
Yeah, go ahead.
Kathy, I've taken several of Kathy Cohen's courses. They're fantastic, and I can only claim them as category 2, which to you is CEU. It's too bad that that isn't CME approved. If we have the special interest group, things like that could occur, and all these courses could be for physicians. Once a physician can get CME for these,
Yeah.
take them. I took them anyway because I have so much CME. It's ridiculous. I don't need. But anyway, that's
Thank
one
you.
thing.
All right, Leslie Marshall is asking Dr. Hartz, was it called Essential Anatomy 5?
Yes.
And can you please give the name of the other app? Everybody get your
It's just
pens
called
ready.
Trigger points. Let me go.
The app is just called, I wouldn't do that.
It's just
Yeah,
called
sorry.
Trigger points.
It's just called Trigger Points. You might find it in your app store. You have it on your iPad, I know.
Yes, I do.
So there's an app store through the iPod. And then Nicole, you here from Chicago, one of our colleagues
I'm gonna show you the-
in a Trigger Point seminar. Put me in, coach. Thank you so much, Nicole. We're going to sign you up. Really good. Too bad you couldn't be here today. All right. So
Show you
everyone
the
wrote
apps.
that down. And then Dr. Hartz. Oh, go ahead. Dr. Hartz is loading your iPad. The question is, did I miss what the term myofascial rejuvenation means?
Yes, myofascial rejuvenation. You know the R's of Dr. Passamonte? Rehydration, this, that, the other.
Mhm.
Myofascial rejuvenation covers all of those. It's my trademark. It includes multimodal therapy, includes evaluation, examination, perpetuating factors by a physician or a physician extender. It includes point injections. It includes subsequent myofascial therapy with your adjunctive methods, all the methods, and finally self-care education. So that myofascial rejuvenation is multimodal. Okay, and I don't do any stippling or any of those things that the dry needlers do. And I use a single clean stick. Once you do these after a while, by the way, I have a practicum. I have 10 slides in a practicum, which Mary will get to you, and I'll probably point out why I chose these. I have 10 different trigger point areas in that practicum, and I want you to see it. But again, that's just one small part of it.
Yeah.
I was granted that trademark almost overnight, as opposed to trying to get fibromyalgia. They didn't grant me
Right.
that, but that belongs to the organization, to you guys. What we do.
Okay. So we're
I
going
can't do myofascial rejuvenation because I'm there as a therapist.
I do not have the ability to type in the app for those of you.
I'm gonna show you a picture.
Nope. Yep. Just get your pens out. I do not, because I'm the moderator. I do not. So it was Essential Anatomy 5. And then the second one was called Trigger Points.
Here. Pause it. Just
Okay.
take a second. There's another question. Go ahead. Mo.
So about that myofascial rejuvenation, it doesn't mean that Dr. Hartz has any trademark claim.
I have no commercial.
No commercial, but she has no claim to any of the modalities that are within. Yet it is the idea that more doctor practitioners need to recognize the importance of the manual therapy component and all the other. It could be e-stim devices, frequency specific, light or laser devices. But I think what Dr. Hartz is trying to say, that it all needs to occur either simultaneously or within a treatment continuum. Within a treatment continuum. Does that make sense? So I'm going to leave Carrie's answer right here. I think if I do it like that, everybody will see it. I don't know. I think I did something. Carrie Bullock from Colorado is saying she also loves the app Dr. Hartz and she uses it all the time. Great.
The Trigger Point, the second app, the Trigger Point app, which is new, does something in addition. You can scan a zone. If you want to scan the knee, it'll show you all the muscles that refer to that location.
Mm.
That's the advantage over the essential line on MB5. The essential line on MB5 is very easy to use. You can enlarge, you can switch from nerve to artery to vein to muscle to connective tissue.
You
They're
can
simple
move
to
it.
use.
It's in 3D,
Yes.
three-dimensional, real, almost like real time.
The
It will
patient's
show you the
crazy.
movement. It'll give you flexion,
Right.
extension, external rotation, whatever, but great.
It gives you, if you isolate that muscle, myofascial, it'll give you origin, insertion, action. You can even get videos. I don't have the videos. I don't need the videos, but some of you might want those videos.
That'd be a little more of a
The
charge.
trigger point, yeah, what, $5 more.
Yeah.
The Trigger Point app shows a therapist doing therapy. And the only thing I can say is that since I really believe that the direction of I almost think that even though it may not be deleterious, massaging in two directions maybe is inefficient. The most efficient to me, and I could be proved wrong, I'd like you to take some shots at me. The most efficient is to relax the layers of the fascia that are extensible and fluid. That is the epi, endo, and paramecium. You're not going to do anything to that origin. That's why I think I probably should rename that.
Perhaps.
Origin's too hard a word.
Yeah. All right. Thank you so much, Dr. Hartz. Really appreciate you. Thank you. So I think what we're going to do is we're going to take about a 15-minute or 14-minute break. Let's get everybody up, go stretch, go drink, go walk, go get some sunshine in your brain. And let's see you guys back here. Everybody set your phone alarm or your timer for, I guess we're going to set it for about 13 minutes or 12 minutes, and let's come back and we'll start right before 3 o'clock. All right.
Thank you for being part of this magical mystery tour.
I wish,
La, la, la.
da, 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 a magical mystery tour.
Is coming to take you away.
Wow. Okay. We'll see you in a few
We're
minutes.
slow, but
We're
and our
lousy.
kids love our mouths.
Okay. See you in a couple of minutes. And yes, oh, one more thing before the comedy show gets off the tracks. We will let everybody know via our newsletter. So we're so grateful for those of you that are on this meeting who are not currently NAMTPT members. We invite you, we urge you. Mary Jo Smiley is our membership chairperson. Her name and her phone number and her email has been in there. You are welcome to take a look at the membership levels. We would love you to be a member. That way then, or you can also subscribe to our emails, because we will keeping you up to breast on the special interest group. So, all right. Thank you, everybody. We'll see you in now 11 minutes.